Thank you so much for joining us this afternoon as Dr. Jennifer Landa shares her expertise and highlights MMI's Module 1, a metabolic and functional approach to endocrinology. Join us for this 3-day module where elite education meets scientific research on the endocrine system and hormonal health. Earn CME credits, interact with hormone therapy experts, learn new protocols, and review new patient case studies in an interactive environment. I'm so excited to introduce Dr. Jennifer Landa. Dr. Landa specializes in helping women and men balance their hormones, restore their energy, and replenish their sex lives. At the heart of her practice is the belief that maintaining one's health is hard work, and she encourages her patients to make lifestyle changes that will result in increased health. Dr. Landa is also the director for the Sexual Health and Treatment Certification Program with the American Academy of Anti-Aging Medicine, as well as faculty member and fellowship graduate for the Fellowship in Metabolic and Nutritional Medicine. Thank you so much for joining us, Dr. Landa. I will turn the webinar over to you.
Thanks so much, Lindsay. This was me in just my early 30s or so. I had basically had it. I'll never forget that one day I put my head down at the nurse's station desk and just started bawling because everything in my life felt like it was falling apart. I felt like I was a terrible wife. I felt like I was a terrible mom. And I felt like I was a terrible doctor. So why did I feel all those things? Well, really, that's kind of what started me on this whole journey to where I am now, having taken the fellowship and transformed my entire practice, really. So back when I was positioning you in my early 30s, I was an OBGYN, and I was, working like a lot of you are, under, an insurance system, under a system where I noticed that all the costs were rising and the reimbursement was falling, and nothing made any sense from an economic point of view. But forget all that. Really, what was going on in my body was just insane. I had no sex drive, and that's why I felt like a terrible wife. I had no energy, and that's why I felt like a terrible mom, because I didn't even want to play with my kids. I was so tired. And when I started to feel like a terrible doctor, it was not only because I didn't have the energy and I didn't feel like I had the focus to be able to learn new things, but I also felt like I was losing my nerve. Like I was scared. Honestly, I was scared when I would walk into the operating room or the delivery room. So essentially, yes, my life was falling apart and I needed a new answer. I wanted to stop practicing OB, and I had no idea what I was going to do next. And that was when I started to get a little bit of an introduction to nutrition and to some bioidentical hormone therapies. And I attended a lecture series that was put on by a compounding pharmacy. And that's when I really got turned on about bioidentical hormones. And I went to an A4M conference, and then I started the fellowship, and the rest really is history. That was where I learned what was going on with me. That was where I learned about the HPA axis and my adrenal glands and the adrenal exhaustion that I was suffering from, which really aren't calling adrenal exhaustion so much anymore, or adrenal fatigue. It's really more about HPA axis suppression or elevation. Anyway, so I learned how all of those things were related to me, and how the traditional therapies that I was prescribing to my patients were the very things that were making me sick. I had been on birth control pills for years and years and years, and it turns out they were sucking up my free testosterone, suppressing my progesterone. Those factors were having a huge impact on my HPA axis and causing all of this exhaustion, absence of libido, all of these things that I was suffering from. And it amazes me now, looking back on that whole thing, how I wasn't able to help myself, and I felt like a fraud. That was one of the reasons I felt like the worst doctor in the world, and I honestly felt lonelier than I'd ever felt in my entire life. And so if the reason you're listening to this webinar today is because you've had some personal changes, either professionally or or professionally and personally like I did, I get where you're coming from, because medicine is just not, it's not what we thought it was going to be. I think when we went into it, it wasn't what I thought it was going to be. And I wasn't happy with what I was doing, and I wasn't happy with the treatments that I was given, and I wasn't happy with the tools that I had, the pharmaceuticals and the pharmaceutical industry. I could go on and on about all of this, really, but I just felt like I wasn't really able to serve my patients the way that I wanted to, and I knew there was something missing, but I didn't really know what it was until I found the fellowship training, and I can't even tell you how exciting Module 1 was for me. I learned more in Module 1 about hormones. In that 3 days, I learned more about hormones than I had, I swear, in my entire time as an OBGYN. And I know that sounds ridiculous, and I'm not downing conventional medicine or my traditional training. I'm grateful that I had that training, because it really gave me a great background to understand the things that I understand today and the ways that I'm treating my patients. And I truly, truly hope that each and every one of you registers for the module, because it truly can change your life. It totally changed mine. And I really think it'll change the lives of your patients. So these are our patients, right? These are very typical looking people for my patients. They're aging and they feel like things just aren't right with them. They feel lower energy. They feel lack of control over their moods. They don't have a sex drive. They may think that's even normal because, oh my, they're in their late 50s. Are you kidding me now? I'm finally getting to that point in life, and I'm like, wow, I can't even believe what people accept as normal, and don't even realize that there are hormonal causes that can be causing these problems. So this is really what we're looking at in medicine, right? This is, I thought this was the most fascinating concept when I first learned about it. The fact is that we are well able to expand the lifespan. As you see on that x-axis, you see the lifespan getting expanded out to 90 years old. But what you see is that people are spending the last 30 years of their lives in significant decline. That's that heavy black line. That's where we are now. But where we want to be is that gray line that's way further out, and that basically squares off the health span curve. So the idea is not to increase the lifespan. Well, yes, to increase the lifespan, but while we're increasing the lifespan, we want to increase the health span. We want our patients not only to live longer, but we want to be healthy. Right? Who doesn't want to be healthy, vital, and strong until the day they drop dead doing something that they love, right? That's what we all want. And that's what our patients want. And that's what we want to be able to deliver to them. And I really feel that that's what I've been able to learn how to deliver. So on a totally other tack, going back to the biochemistry that you loved so much in medical school, I know, and you never thought you'd have to see again. Well, my friends, the fellowship and learning in Module 1 about endocrinology is really all about the hormones and the hormonal web. And what I want to highlight here, I know it's a busy slide, but basically just the bottom line is right in the middle, you see that DHEA. DHEA is the most abundant hormone in the body, and it's one that we learn so little about. But when you look at the hormone chain to the right, DHEA is the precursor hormone, the mother hormone, if you will, for estrogen and testosterone. So it's super duper important. But look at what happens to DHEA as we age. It reaches a peak at around 20 years old. And by the time that we're 90 years old, we only have about 10% of the DHEA that we had when we were 20. Isn't that unbelievable? Especially since DHEA, like I just told you, is the mother of all hormones. So of course, as DHEA goes down, all of our hormones are going to go down. For women, our estrogen and progesterone is going to go down. Even for men, estrogen declines. And believe it or not, that's a problem. That's something that a lot of people aren't aware of, but it is a problem when estrogen goes down in men. And so not only that, but of course male testosterone, and I'll show you a slide on that later. And these things really are a big part of what causes people to age. Now, it would be a way oversimplification of the aging process to tell you it's all hormones. I know that. But what I am telling you is that a large part of the negative consequences that we experience as part of aging can be avoided by keeping our hormone levels in the optimal range. We'll talk more about that optimal range in a few minutes. Stress. Stress is something you can't get away from nowadays, right? It's everywhere. And I just want to reflect for a moment, because nobody ever taught me about this in medical school or residency, about the effect that stress is having on my HPA axis and on my HPG axis, the hypothalamic pituitary gonadal axis. Look at how much is being affected. All of my hormones, basically, right, are being affected by stress. Anything from, of course, follicle stimulating hormone, luteinizing hormone that helps stimulate testosterone, ACTH, which stimulates cortisol production, so the HPA axis, all of these things, all of these processes that are central to what's going on in the body. The thyroid hormones are affected by stress. So it's not only aging that's happening, but it's stress that's happening. And stress that's happening more than any society I think has ever seen. You know, we are stressed constantly, not only by our 24/7 go lifestyles, but also by environmental stressors, what I call physical stressors, pollutants, pesticides, all kinds of things. We're exposed to more chemicals than ever before. We're exposed to way more chemicals in our food supply, the chemicalization, if you will, of food. Really, food is practically unrecognizable compared to what it was just 100 years ago, let alone 300 or 500 years ago. So let's talk about those optimal levels. I don't know about you, but in medical school and residency, I really learned very little about anything about the adrenals, and all I learned was, well, it was probably about an hour lecture or so, maybe 2 or so, telling us about Cushing's disease and Addison's disease. And that was about all there was. And then when you look at normal levels, this is really important to consider. You're basically looking at a bell curve, right? And if you're outside of the second standard deviation, then you might be considered low or high. But what if you're inside the standard deviation? What if you're in between the first and the second deviations? What about those people? Might they have symptoms even if they don't meet our cutoffs? Yeah, they definitely do. And that's one of the huge differences in practicing the way that I practice now in metabolic medicine, is that I have a whole different list and standard for what I consider optimal. I don't look at normal levels anymore. I look at optimal levels. And that's one of the things that I've learned through all of this education. I've learned what are the optimal levels to keep people in optimal health. And that's a really important, crucial concept. So testosterone, that's a good example of it. Testosterone decline leads to symptoms of male aging. Simple, 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 right? Basically, all the things that grumpy old men think are just because they're old, a lot of them are because of the decline of testosterone. And unfortunately, the major labs across the country that most of us use, say that the level of normal testosterone is anywhere from 250 all the way up to 1,100 nanograms per deciliter of testosterone. Well, of course, that's taking account men from the ages of 18 to 80. But what about your patient? Where do they want to be? Well, most patients, if you talk to them, want to be somewhere at around where they were when they were around age 25, maybe 30. And it would be great if we knew where they were at age 25 or 30, but we don't for the most part, because unfortunately that's not considered a standard of care, where maybe in the future, someday, maybe it could be, which would be great. So most guys feel a lot better when their testosterone is higher. You know, we're still We're still looking at what are those optimal levels exactly, but I would say it's probably more somewhere between 650 and 850, maybe somewhere up there, which is really akin to what a guy would have when they're younger. And, unfortunately, our patients are told their levels are normal when they're really low. And the scary thing is, we used to think that prostate cancer was caused by testosterone and that increasing testosterone levels might increase prostate cancer. But now the data shows us that actually having a very low testosterone can increase your risk of prostate cancer. Yes, if you're not sure if you heard me right, I said a low testosterone can increase your risk of prostate cancer. That comes from work done by Abraham Morgentaler. He wrote a great book. If you haven't read it, called Testosterone for Life, I would definitely suggest picking that one up. So recently there's been all this noise about testosterone and cardiovascular disease. I will tell you, study after study after study, including this study right here, shows us that men with lower testosterones have a significantly higher all-cause mortality and higher vascular mortality. It's been shown study after study after study, regardless of the most recent rash. There have been three or four studies in the last year or two that were terribly poorly done. They've been reviewed up and down. Morgenthaler, that guy I just mentioned, he wrote a scathing review of those studies. We have a stack of literature going back many, many years that shows us that low testosterone is certainly associated with a higher risk of coronary vascular disease and death in general. What about women? Oh my goodness, the biggest travesty ever. You see that spike in the women discontinuing hormone replacement in 2002. Honestly, the worst thing ever, to me, the biggest travesty ever promulgated upon women. It was the WHI study. And I'll talk about that to some extent in the module, and you'll hear a lot about it and why a lot of the things that you might not think about that study are not true, and about the fact, basically, because they picked hormones that are not bioidentical, not the same exact as what's in a woman's body naturally, like estradiol and natural progesterone. Because that's not what was studied in that study, they saw an increased risk of breast cancer in women who got the artificial form of progesterone, the progestin medroxyprogesterone acetate mixed with estrogen. Those women had an increased risk of breast cancer. Interestingly, in the study, when you took away the progestin, the medroxyprogesterone acetate, the women who just got the horse estrogen, which I don't love, that's not my favorite form of estrogen because it's not bioidentical for a woman, but even those women had a decreased risk of breast cancer. It's very important that you know that. So estrogen does not cause breast cancer, and that's what so many people walked away from that study thinking. Then the other question is, does estrogen or the combination of estrogen and progesterone cause heart disease? And the answer to that is emphatically no, even with the poor combination chosen in the WHI study. When they parsed out the data for years afterwards, what they determined was that women who start hormone replacement between the ages of 50 and 60 have a lower risk of heart disease. A lower risk of heart disease. And that's really sad, because women who stopped hormone replacement or did not go on hormone replacement in 2002, who were between 50 and 60, let's say, they didn't start hormone replacement because they were scared. And then 10 years later, when all of the data had been parsed out, they find out, once after they've turned 60, that it may be more dangerous for them to start hormone replacement therapy after 60, and that they should have started it when they were newly menopausal. Well, doesn't that stink? That's why I think it's a terrible travesty upon women, unfortunately, and that hormone replacement absolutely can decrease the risk of cardiovascular disease and not increase the risk of breast cancer. What about testosterone decline in females? This is really interesting and important. testosterone levels in females actually take their biggest nosedive between the ages of 18 and 34. And that's why so many women on birth control pills can be affected by this issue, just like I was. I was 28 when I first started to notice my libido going away. And the birth control pill decreases free testosterone because taking oral estrogen increases sex hormone binding globulin. And we know if we bind up the sex hormones, that means the free testosterone will decline. And free testosterone is the only testosterone in the body that's free to bind to your receptors, right? So that's going to have a huge impact. And on some women, bigger than others. And the really scary, sad part is what they've determined in some studies is that the rise in SHBG that happens to women who are on the birth control pill, that rise can last forever possibly. Even after women have discontinued the pill for many years, we've seen a persistence of that rise in SHBG, so a persistence of the low free testosterone and the need to possibly be on testosterone therapy to have a normal libido and to have, forget just libido, testosterone in women, women only have 1/10 the amount that men have, but it's a very important hormone for them for energy, for memory, for mood. There's so many wonderful benefits for testosterone in women who are deficient. So let's look briefly at a case study here. This is a patient of mine. She's a 60-year-old woman. She'd been seen by another practitioner for hormones but wasn't satisfied on her regimen. Now you're going to see a lot of this now because hormone therapy has been around for a long time now, and a lot of people will come to you from another practitioner. This patient had had a laparoscopic hysterectomy in 1990 and started traditional HRT within 3 years after surgery, but eventually changed over to BHRT, bioidentical hormone replacement therapy. She had recently tried an increased dose of progesterone that resulted in terrible night sweats. Keep that in mind. She also was concerned with her weight and craving sweets. She doesn't sleep well. Energy comes and goes. Her sex drive is gone. She wants to lose 30 to 50 pounds. She's also concerned with hair loss, and she gets very shaky when she misses meals. Well, I'll tell you, what I'm seeing and hearing here is somebody who's on bioidentical hormone replacement therapy, which she thought was going to be the answer to everything, and which, when I first started prescribing bioidentical hormone replacement therapy, I thought was going to be the answer to everything. But then I found out that there can be tougher cases, and there can be exceptions to the rule, and there can be lots of little ups and downs and pearls and all kinds of things to be learned from people who've been doing this in the field for many, many years. So I learned a lot of things myself over the years by all kinds of trial and error, but also from the amazing teachers in the modules that I've attended. And being an advanced fellow, I've attended many, many modules and learned a lot from my teachers. So anyway, this particular patient, to go on, her past medical history was essentially negative. She was on a combination called biased, 50-50. So when we say biased 50-50, that means 50% of the estrogen was delivered as estradiol, or E2, and 50% of the estrogen was delivered as E3, estriol. So she was given a 1 milligram troche, or troche, however you want to say it. I still have never convinced myself of what the proper pronunciation is. I guess it depends if you're French or not, right? Anyway, and she was given a 100 milligram progesterone troche. And then, so the surgical history was just the laparoscopic hysterectomy. She had interestingly had a history of fibrocystic breast dysplasia, but recent screening tests were normal. Nothing else too exciting except for her exercise. She did tell me that she used to ride 100 miles per week on her bike, and now she can't ride more than 25 miles an hour. So she was getting physically tired and had decreased stamina. She had a family history of some cancer, cardiovascular disease, but at an older age. She eats a lot of whole grains, sometimes has desserts. Her energy, she said she had a low point in the late afternoon, sometimes comes back and sometimes not. So here was her salivary testing, which you may or may not be familiar with these levels, but I included the normals so that you can briefly see, and I highlighted in bold the numbers that were abnormal. So her estradiol, you can see her estradiol is way off the charts high, right? Her progesterone is actually on the low side. Her progesterone to estrogen ratio was very low. Now that's important, the balance of progesterone to estrogen. So you want to have between 100 and 500 molecules of progesterone for each one of estrogen. So you want to be essentially progesterone dominant, but in this case, this woman was estrogen dominant. She had low testosterone because she wasn't on any testosterone, and her levels had naturally declined. She also had a low DHEAS and low and high cortisol levels. High cortisol levels. She, the only thing that was outstanding in her lipid panel was her triglycerides were 192, and nothing else really too exciting there. So there's a lot of things that this gets me thinking about. This gets me thinking, well, for one thing, that her estrogen levels were too high relative to her progesterone levels. But then, this case is a little complicated in many ways because the woman was on troches. So with troches, I really personally don't care for them anymore because now that I've been doing, actually I do a lot of urinary hormone testing now, and now that I see in the urinary hormone testing, especially estrogen, there are plenty of studies that show us that estrogen, when given by mouth, increases the risk of clotting and increases the risk of stroke. It increases HSCRP. It increases triglycerides. So it has a lot of negative effects. And when you give a patient a troche, no matter how hard they try, 50% of it is going to be swallowed, and the hormone will act as if it was taken PO by mouth. And that causes a first pass effect through the liver that can increase these different risks that I just told you about. So I don't love the troches for that reason. Anyway, so what do you think? So I've told you a little bit about what I think. So what I think here is the estrogen dominance, like I said, and I also see HPA, hypothalamic pituitary adrenal axis upregulation. She had high cortisol levels, but she had low DHEA. So what's going on with that? Well, the speakers in Module 1 will tell you a lot more about what's going on with the HPA axis, but what this tells me is that she has early HPA axis dysfunction. So what did I do with her? I gave her some biased cream. I gave it to her in an 80-20, so 80% being estriol and 20% being estradiol. And I gave her progesterone capsule and progesterone cream. And I gave her some testosterone cream. I gave her some fish oil, a multivitamin, and some adrenal support supplements. So keep in mind, I know I've just thrown a lot at you, but the bottom line is hormones are a web. Hormones are absolutely a web, and what you give one hormone affects the other hormones. And so you always have to keep that in mind. So I talked a little bit about the oral versus cream versus troche on the estrogen. What about the oral versus the cream progesterone? Well, sometimes I do a combination, and it depends what I see going on with the patient. So I'm going to go into more detail about this, why I do oral at times, why I do cream at times, and the effects that progesterone can have on the HPA axis. And then testosterone effects. So what about testosterone's effect on estrogen? Well, keep in mind that testosterone can be aromatized to estrogen. And then what about the effects on cortisol? Well, this is all stuff that I'm going to go into more in Module 1 so that you can really get a handle. It's way more than I can cover in this little webinar that we've got here. And then the adrenal support supplements. So I used in her Siberian ginseng and rhodiola. In her, I would not use licorice because she has high cortisol, and licorice can cause cortisol to stay around longer. So you've got to know which ones to use and which ones to avoid, and there'll be lots more interesting information about this in Module 1. All right, and let's see, so we'll go on to the next. So recommendations, so of course I gave her recommendations to reduce her stress, easier said than done, right? And I told her not to exercise too hard because that would actually fire up her HPA axis even more. And to avoid caffeine and sugar because those fire up the HPA axis as well. So now I'm going to show you that this was a case that's very old for me, and it was a case where I made some mistakes. And I wanted to show you that because I think it's important to see the mistakes that we make. So the patient called, she had hot flashes day and night. I increased her bias because, of course, hot flashes are due to low estrogen, right? So she got a little bit better, but she told me she still felt like she needed more. So I made the hormones stronger by changing to a 50-50 because estradiol is stronger than estriol. And then she still had a lot of hot flashes, so I increased her bias again. And she felt better, but the hot flashes were only a little better, only a little. And her numbers had come into a little bit better alignment. And then what I did was I started addressing other causes of hot flashes. So another cause of hot flashes that you may not be aware of is that high cortisol itself can cause hot flashes. So what I did was I started working more on her adrenals on giving her supplements that would help lower her cortisol. And that's exactly what phosphatidylserine, or PS, we call it for short, that's what phosphatidylserine does, and that's what ashwagandha can do. And then she wound up doing much better. She felt like she was back to being a normal person. She felt like her moods were better, her energy was much better, she was sleeping better, she was just doing better all in all. And she was, doing a lot of changes in her lifestyle. She was controlling her sugar intake and carb intake, so she controlled her cravings. She was staying off caffeine. And she was feeling so much better that she hired a personal trainer and was doing private ballroom lessons and just started to have an amazing result. And it was because I looked at things in a different way. So hot flushes from high cortisol, these are some of the things that I've found in the literature, that hot flushes coincide with a rise in cortisol, that more severe hot flashes are associated with rising cortisol. And a cortisol rise also follows a hot flash. And these are some of the references that I found for hot flashes with particularly correlating with cortisol, which I thought was very, very interesting. So that's another thing to keep in mind, that when we tell you stuff in the fellowship, we base it on what's in the literature. It's in the science. I think the reason a lot of it gets ignored is because there's no pharmaceutical that goes along with it. If I think back to the days when I practiced conventional medicine, most of the scientific studies I ran across were provided for me from a pharmaceutical rep. It wasn't that I was, hunting and searching the literature myself for other options, other opportunities. And that's what me and all of the speakers in the fellowship do now. We're constantly poring over the literature to bring you the newest, most up-to-date information. Like my lecture on estrogen dominance in Module 1 is going to be all about brand new research that shows how endometriosis and fibroids are actually an inflammatory process, and we need to address inflammation if we're going to be able to really help our patients with those diseases. And I love that because I was so challenged by those, obviously, as an OBGYN. So I think it's time for you to control your stress, the stress that you feel, probably like I felt years ago when I wasn't able to provide the type of care that I wanted for my patients. And the stepping stone for me was the learning that I had in the fellowship. And I hope it will be the same for you. And I hope to see you at Module 1. And I'll leave you with this thought because it amazed me that Thomas Edison 100 years ago said, "The doctor of the future will give no medicine, but will interest her or his patients in the care of the human frame, in a proper diet, and in the cause and prevention of disease." So join me in learning how to prevent diseases by optimizing your endocrinology in Vegas at Module 1. Hope to see you then.
Thank you so much, Dr. Landa. We definitely appreciate you sharing your expertise and highlighting this educational opportunity. For those of you that are new to the fellowship in metabolic and nutritional medicine or have completed this module in the past, this opportunity is for you. Come out and earn your CMEs, participate in interactive case studies, engage with our expert faculty, and also network with many like-minded experts in the field. Thank you so much for your time. If you would like to register for this module, my direct line is 561-777-6807. Thank you so much, Dr. Landa. Have a fantastic day.
Thanks, you too, Lindsay.